Our next speaker today is Dr. Manjunath Pai, who is an Associate Professor of Clinical Pharmacy and Deputy Director of the Pharmacokinetic Core Laboratory at the University of Michigan. Dr. Pai's research focus is on optimizing drug dose selection in special populations such as obesity. He earned his Doctorate of Pharmacy degree from the University of Texas Health Science Center and completed a pharmacy practice residency at Bassett Healthcare, followed by an infectious disease and pharmacokinetic fellowship at the University of Illinois at Chicago. We know you will enjoy today's lecture.
Hello, my name is Manjunath Pai. I'm an Associate Professor of Clinical Pharmacy at the University of Michigan and the Deputy Director of the Pharmacokinetics Core. It's my pleasure today to present on the pharmacokinetics of obesity. This slide contains my disclosures. What I'd like to cover today is reviewing the definition and epidemiology of obesity, explain the effects of body size on drug exposure with a focus on antimicrobials, demonstrate the similarity and differences in body size scalars for drug dosing, and explain the rationale for alternate approaches to dose selection in obese adult patients. This graphic gives a global distribution and prevalence of obesity in adult females and males across the world and in different parts of the world. As you can see from this graph, obesity has more than doubled since 1980, from almost less than 20% to over 35% in the United States, and similar trends are seen in the developing countries represented by the BRIC nations, Brazil, Russia, India, and China. Based on current definitions, in 2014 over 600 million adults were classified as obese, and this is really important because the consequences of overweight and obesity kill more individuals in the world today for the first time in history than underweight individuals, than the effects in underweight individuals. This is the prevalence of obesity across the United States by county, and clearly there's diversity in the prevalence of obesity in the United States, with the lowest rate seen in Routt County and the highest in Greene County, which again, this area here represents the southeast part of the United States. It's also associated with a high prevalence of diabetes. And when we think about obesity, an important point is the definition and prevalence of obesity. And when you think of obesity, this definition, the original definition was derived by Adolphe Quetelet in 1835. He came up with the body mass index definition, which is basically the weight of an individual divided by height in meters squared. And the purpose that Adolphe Quetelet sought was basically to find a correlation between body size parameters and different events, such as probability of criminal behavior. And so when you think of this metric, it was really not designed for a pharmacologic purpose or for other classification purposes. And not until 1972 was this index transformed into what we call today as the body mass index, a term defined by Dr. Ansel Keys, who did a lot of the initial work on the effects of starvation in humans. Based on this definition that was adopted by the National Institutes of Health in 1985, body mass index is categorized into three major categories for obesity, and those are obese class 1, between 30 and 34.99 kilogram per meter squared, to obese class 3, which is greater than or equal to 40 kilogram per meter squared. And so again, this classification is broken down into units of 5 in a way for simplicity, but these may not necessarily correlate with predictors or prognostic variables such as incidence of diabetes. So if you look at specific populations, Asian versus Caucasian, the risk for diabetes actually increases when the body mass index is greater than 27 kilogram per meter squared. Irrespective of that, current definitions are based on an obese categorization of 30 kilogram per meter squared or greater. Based on that definition, 1 out of 3 adults in the United States meet that definition, and 1 in 6 children meet that definition. Now when you think about body mass index, it's clearly not a perfect index because it doesn't represent the true body weight composition when you're thinking of extremes of individuals in height. And so here's a graphical representation of two individuals from the movie Twins, demonstrating Arnold Schwarzenegger with a body mass index of 34 kilogram per meter squared and Danny DeVito with a 35 kilogram per meter squared, who clearly have very, very different body composition but have very similar BMIs. And this is important because BMI again was adopted in 1985, but several of our pharmacologic studies were based on another metric known as the ideal body weight. This is based on height and gender. It's a very simple rule, and I'm going to go over that specific equation and explain the origins of that equation. That equation has been used in several pharmacokinetic studies, and in general terms, individuals who are 20 to 30% above ideal body weight are categorized as being obese. Despite these definitions of obesity, there really hasn't been much progress in modifications of product labels to provide specific dosage recommendations for obese individuals. This is important because this drives a lot of dosage selection, and our current paradigms and product labels are based on three scenarios. One is dosing individuals based on their body surface area. This is a common practice in oncology. Weight-based dosing, common practice in antimicrobial chemotherapy. And when it's weight-based dosed, this is often based on total body weight dosing, or in some labels as lean body weight dosing. But the predominant approach to dosing drugs is using a fixed dosing strategy. This is using a dose, for example, 500 milligrams irrespective of body size. But this always raises the question that if you use a fixed dose across a population of adults, is using the same dose sufficient for a 65 versus 130 kilogram individual, for example? This dosing controversy has also been seen in oncology despite body mass index dosing. A study by Griggs and colleagues showed that 37% of women with a body mass index over 35 kilograms per meter squared received lower standard first cycle doses. Obese patients were also seen to have lower risks of grade 3 and 4 toxicities despite using higher doses. And this in part may be related to underdosing these individuals. A survey by Fields and colleagues showed that 80% of oncologists dose capped at 2 meters squared. Again, the idea here is individuals felt that they were overdosing individuals when they used total body weight to compute body surface area, and have in the past arbitrarily dose capped at 2 meters squared. And this is important because this can lead to underdosing individuals, especially those individuals who are at greater risk for cancers that are associated with obesity, such as breast cancer and colon cancer. Because of this discrepancy, efforts by Griggs and colleagues and several investigators around the United States has led to issuance of guidance by the American Society of Clinical Oncology against capping these doses and actually using total body weight to compute body surface area. And what I will do today is explain the mathematical rationale for why that is the right approach of computing body surface area. This has also been seen with anticoagulants, looking at the Crusade trial, which did include about 1 out of 5 individuals over 100 kilograms. 80% of patients over 150 kilograms received below the standard dose, and those individuals that were likely to receive the standard dose actually were at a higher risk for bleeding. And so this is an example of a drug that has been historically dosed on body weight, and a scenario where using body weight may lead to overdosing the drug and lead to events such as bleeding. Other groups have shown that individualized dosing using lean body weight equation, which I'll also review, is actually less likely to cause this problem of bleeding and bruising in obese patients, and so may serve as a better metric of dosing patients on enoxaparin. So the question at hand is really, do bigger adults need bigger doses? And so conceptually, overdosing is likely when you use weight-based doses because using the same milligram per kilogram dose across a body distribution can lead to computation of much higher doses. The opposite is true with fixed dosing. Using the same dose across a population can have the opposite effect of leading to lower exposures in larger individuals. And so it's really balancing these two dosing paradigms that we have to consider really on a drug-by-drug basis. So let's think of that dose selection from a pharmacokinetic perspective. And when you think of it from a pharmacokinetic perspective, a key concept is that of bioequivalence. That is, trying to ensure that individuals across the population have the same or have similar exposures. And that exposure can be quantified by the area under the curve, that is assuming having a similar AUC across a population, or having similar peak concentrations of the Cmax concentration. And so when this is administered, when the drug is administered orally, we also think of other parameters such as time to peak concentrations, or the Tmax. Or in some multiple dose studies, we may also consider the minimum concentration or trough concentration as a metric to assess bioequivalence. Now, I think it's really important to separate the concepts of dose and exposure because they're certainly related but can vary across a population. So if we give a 1 gram dose to 3 individuals, for example, those 3 individuals can have very different concentration time profiles. And so when we simulate that across a population, we may get a distribution represented here in this histogram as a distribution of AUCs for that population. And that happens because we may have a lot of inter-individual variability in the volume of distribution that impacts the peak concentration, and inter-individual variability in the clearance of a drug that can impact the AUC, or area under the curve. So when we think of these pharmacokinetic parameters, the volume of distribution is often a term that's easily confused. It is not a physiological space, but rather a proportionality constant that represents the apparent size of a compartment that the drug will fill. And when you review the literature for a specific drug, what you may see is a lot of different V terms. And so this really depends on the method, the mathematical approach that was used to compute the volume of distribution. So if you use a non-compartmental method, you may see the value reported as VD or VDSS. If you use a 2-compartment approach, you may see the value reported as VC and VP, which represent the central and peripheral compartment. And if you have larger compartments describing this, you may see this numbered as V1, V2, and V3, and so on and so forth. These volumes essentially are used to help fit the shape of the concentration curve, and again, they do not represent an actual physical space. They're helpful because they can help compute the Cmax, or the peak concentration, and here represented by this equation is a very simple way of thinking of this, which is if a dose was administered as a bolus, that dose divided by the central compartment value gives you some estimate of what that peak concentration would be. The clearance is then just the mathematical representation of volume that's being cleared of drug in unit time. And that parameter is useful because it can help compute the AUC, or area under the curve, represented again very simply as the dose divided by clearance. Our objective most often when we're thinking about bioequivalence is to achieve isometric AUCs across a population. And to do that, what we really need to do is ensure that clearance scales with body size. So if you're going to dose a drug based on body size, we want to ensure that that scalar is really representative of clearance. Another perspective when we're thinking about optimal dose selection is the pharmacokinetic pharmacodynamic, or Pkpd perspective. And what's done here is essentially looking at the concentration time curve and breaking it up into different parameters. So often what's done is to look at the peak concentration of the Cmax, the area under the curve, or the AUC, and the trough concentration, which is the Cmin. These values can then be scaled to a potency measure. In this case, looking at antimicrobials, we rely on something known as the MIC, or minimum inhibitory concentrations. And we can then index the pharmacokinetic term with a potency measure such as Cmax over MIC, AC over MIC, or the time above that MIC. Once we have those parameters, we can then look and see which of those parameters best correlates with the effect of the drug, the safety of the drug, or some other measure. It doesn't not have to be effective. It could also be emergence of resistance, for example. Once we do that, the parameters that best predict effect help us classify that drug as either being concentration dependent or time dependent. And that helps us decide whether we should dose a drug once a day or multiple times a day. When we use that principle, we can, in essence, bucket drugs into different categories. And so when we see drugs that are correlated by their Cmax to MIC and AUC to MIC, we tend to refer to those drugs as being concentration dependent. When we see drugs that are really predicted by their time above MIC, we refer to those drugs as being time dependent. And when we look at antibiotics specifically, what we see is that AUC to MIC really categorizes most of the drugs. And the reason for this is AUC is really a mathematical representation of concentration and time. And because it has both of those parameters, this parameter often correlates with effect. Beyond just looking at Pkpd, we can also look at how drugs are currently dosed. And when we look at antimicrobials again, they fit the pattern that we would expect. That is, most of them are dosed on a fixed basis, that is using the same dose across a population. A few of them, like the aminoglycosides and polymyxins and other drugs similar, that are dosed on body weight, usually on a milligram per kilogram basis. And then some drugs actually have recommendations for both a fixed dosing strategy and a weight-based strategy. And so let's review again why this may or may not be appropriate. Again, going back to the pharmacokinetic term of volume of distribution, what you have here is two individuals who are represented roughly twice in body weight, having very different body compositions. But what volume of distribution really represents, again, is nothing physiologic. It simply represents a proportionality constant. The value is then indexed to body weight, and so is often reported as liter per kilogram. That parameter helps us define what the peak concentration is, and also as that value gets larger, it impacts the terminal half-life of the drug. But again, this term does not represent biodistribution, but just represents a physical space, which is again very simply represented here and does not reflect the physiologic space. Now let's simulate what would happen in two individuals based on their body weight if volume increased with weight, but the clearance of the drug did not increase with weight. So what you have here in blue is an individual that's 60 kilograms versus 120 kilograms, so roughly twice the body weight. What you see in these profiles is because the volume of distribution is smaller in the smaller individual, you see higher concentrations. The effect of this is going to be lower concentrations of the drug early on, but because the clearance is not changing, the area under the curve actually will be identical for these two simulations. What you again will see is a lower Cmax, but you'll also see over time a higher Cmin. So when you're thinking about a drug where the volume increases with body weight but clearance does not, this may be beneficial for drugs that are time dependent, because what you'll essentially have is increasing time above a threshold concentration. Where this may be risky is if that time above a threshold is associated with toxicity or some sort of adverse event. Now the solution, if the effect is needed to be early on, for example if you're using a drug for surgical prophylaxis, then this can be overcome by using a higher initial dose to achieve the same concentration profile later in the regimen. When we think about clearance, this again is taking that volume and computing how much of that volume is clearing drug over time, so it's represented by liter per hour. What we know is this parameter really does not increase in proportion to body size. So what you saw is a reduction that is not proportionate to body size, but often represents about a 50% increase as body weight doubles, for example. The terminal half-life is inversely proportional to this parameter, and so this parameter also affects the half-life of the drug. Here's another simulation using the same principles again, 120 kilogram versus a 60 kilogram individual. Because the clearance increases but the volume does not increase, what essentially happens is you will see a lower AUC, you will see a slightly lower Cmax over time because the Cmin and trough concentration is also decreasing, but the principal change is a reduction in the AUC. And so in this scenario, what you will see is the potential for failure if lower AUCs are associated with lower effect, and that's often a case that's seen. You'll also see propensity for emergence of resistance if the dose is not modified with increasing body size. So the solution in this scenario is the need for a higher dose and really the need for a higher maintenance dose. So when you think about all these different scenarios that have been presented so far, what are the actual physiologic changes that we've seen? One of the things, one of the studies that's really done this well is a study done by Jeffrey Young and colleagues at the National Toxicology Center that have looked at autopsy data in over 300 individuals to sort of quantify what happens to tissue as body weight increases, and have created mathematical models to explain this. What you see in this graphical representation is an expectation that when individuals are over 100 kilograms, what you really see a gain in is a gain in adipose mass relative to muscle mass. When you think of the specific organs, what you see is most organs will increase in size, such as the heart, lung, kidneys, and liver, but they'll usually reach a max of no more than a twofold change in size, and perhaps a threefold change when you're thinking of muscle mass. But again, these organs responsible for clearance of drugs do not increase by more than twofold in size across an almost fivefold distribution of body weight. Now this is important because, again, when we're scaling this information, we really need to consider how does the change in body weight impact the change in drug clearance. When you're thinking about distribution and metabolism, in general, there are not a lot of great studies that have done this. It's not really well characterized, but we can have general trends when we're thinking about drug distribution that can be based on the physiochemical properties of the drug. Typically, what we see is where we're dealing with drugs that are more acidic, we tend to see smaller volumes of distributions compared to drugs that are more basic, that can be sequestered within tissue and tend to have larger volumes of distribution. When we're looking at metabolism specifically, looking at the Cytochrome P450 system, what has been evaluated has been specific probes of Cytochrome P450 3A4, 2C9, 19, and CYP2D6. And these studies that have looked at specific probes of those pathways have seen limited effects of increasing body size and metabolism. An area where there has been a 1.5 to 3-fold increase in clearance has been through the Cytochrome P450 2E1 isoenzyme system that's really not responsible for the metabolism of a lot of drugs. This isoenzyme system is responsible for the metabolism of more lipophilic compounds that are typically less than 200 Daltons in weight, and so this can impact some anesthetics, it can impact a key probe substrate known as chlorzoxazone, and the metabolic profile of acetaminophen into its more toxic metabolites. Again, this pathway does not influence the metabolism of most drugs. So when we think about CYP metabolism in general, we do not anticipate an increase in the metabolism as individuals increase in body size. Now when we're accounting for these parameters, clearly weight that we've spent quite a bit of time so far discussing is really a parameter that tends to correlate with the volume of distribution. When we look at clearance, there are several factors that are usually accounted for in population PK studies that look at race, height, weight, age, sex, serum creatinine. There are also several intrinsic variables that I won't have an opportunity to cover today, but discuss that include pharmacogenetic variation. There could also be extrinsic variables such as the impact of smoking or dietary changes that can impact clearance. But typically these are the parameters that are looked at, and often these parameters are consolidated into a variable such as kidney function that incorporates some of these parameters into a composite parameter that correlates with clearance. Again, we tend to treat in population PK analyses these terms to be independent, but they can be interrelated. For example, height clearly correlates with sex, and so that may not necessarily be an independent parameter when incorporated into these models. What I did earlier is show changes in body size, how those body size changes relate to tissue changes and organ weights. But how do those actually relate to function? And so this is one of the few studies that's done this really well, and this is a study done by Avi Shagnak and colleagues who have looked at healthy obese individuals. These are, again, defining healthy obese individuals is quite complicated. These are individuals who did not have hypertension and diabetes but were very large in body weight. And so looking at these individuals, similar age, they looked at glomerular filtration rates, and when you look at these again, although individuals were almost twice in body size, what you see is only a 62% increase in the glomerular filtration rate. And this is again consistent with several animal model experiments that have also shown similar trends for increases in GFR relative to body size. Another study by Friedman and colleagues has looked at the population pharmacokinetics of iahexol, which is another marker that can be used to compute glomerular filtration. And if you do a simulation using that population model, what you also see is if you look at the change in body weight between 50 and 200 kilograms, you would not anticipate the glomerular filtration rate to increase by more than 60%. And so there are several data sets that essentially show that we do not expect body weight to increase mechanisms that would be associated with drug clearance by more than 50 to 60% on average. Now, in the clinical practice, we often cannot measure the creatinine clearance or estimate the glomerular filtration rate, and so we often rely on equations. And so what I'd like to point out here is that there are really two broad ways of doing this. One is using the eGFR or estimated GFR equations, and this method currently incorporates serum creatinine, age, and race, but does not incorporate body weight. Instead, that parameter is sometimes modified in individuals by converting this term from a scalar that's benchmarked to body surface area to a non-normalized term. This equation also has been calibrated using the isotopic dilution mass spectrometry traceable creatinine, which is currently the standard to ensure that creatinine measurements across institutions are similar. The more classical equation that is actually incorporated in clinical trials over the last 40 years has been the Cockroft and Galt equation. This equation that was introduced in 1976 is a simple equation and is often taught in many schools, and incorporates the use of age, weight, serum creatinine. This study actually did not include any females in its design, and so this was an assumption that was placed into the equation with the expectation that women on average have 10 to 20% less lean body weight, and so a term of a 15% lower weight was used in females as an expression. Again, this model was never really validated in females, but has been used over time and shown to be useful for several drugs. Another equation that's emerged is the chronic kidney disease and epidemiology equation. This equation was developed primarily to resolve the issue of the former equation known as the modified diet and renal disease equation, or MDRD equation, that was really restricted to individuals who have GFR estimates less than 60 mil per 1.73 meters squared. So what this equation accomplishes is it permits the calculation of GFR across the GFR distribution. So values below 60 and above 60 mil per 1.73 meters squared. As seen by this equation again, it is much more complicated because it includes several equations that account for sex and race of individuals. But clearly there has been controversy on the use of race as a factor in this equation, especially in multi-ethnic societies. This equation has not necessarily worked out in those populations. Now, this brings us back to, again, use of this term because clearance often correlates with several kidney function markers, but we often dose the drug on body weight for certain drugs. And if we're going to dose the drug on body weight, a scenario that's expected is that the clearance of the drug should increase in a linear and proportionate weight. Instead, what we see is that the relationship is really nonlinear. And the reason why this error may occur is early phase clinical trials tend to include individuals within a relatively narrow bandwidth of body weight. And so if you include individuals that are, for example, between 50 and 80 kilograms, you may consider those individuals to have a linear change in clearance. But when you include a larger body weight distribution in your pharmacokinetic studies, you're more likely to see this curvature and nonlinearity. Now this phenomenon is not an old phenomenon. This phenomenon has been evaluated in several disciplines, and so the principles that are used in pharmacology really relate to principles that were generated in our early understandings of resting metabolism. And so what we have here are two major paradigms that have developed over time. And so this is what I often refer to as the battle of the Maxes. This is Max Rubner's work from the early 1880s to almost 50 years later by work by Max Kleber. Max Rubner's work was a pivotal understanding of the relationship of heat production relative to body surface area. And so his work included experiments that obviously would not be conducted today, but involved the use of animals that were placed in chambers and allowed to starve over time. And what was seen in dogs is heat production declined as a function of their body weight scaled to 0.6. Max Rubner's work really looked at scaling resting metabolism across species, and so in those experiments what was shown is when you plot log heat production relative to log body weight production, log body weight, I'm sorry, what you see is a relationship that has a slope parameter of 0.75. And his original work actually was around 0.73, but again, for simplification, most of the literature reports it as 0.75. Now, this is relevant when we're thinking about allometry because we're thinking about relationships between body size, shape, and physiology. And so often we think of disparate comparisons as apples and oranges. In this scenario, I'm giving you the example of an apple versus a Romanesco. And this is relevant because when we're thinking about computation of surface area, we have to think of the world as either being smooth surfaces or the true phenomena, which is more rough surfaces. So when you think of smooth surfaces, if we were going to compute the surface area of this apple, we would have to think of this apple in 3 dimensions, and the area would simply be the volume of this cube to the 2/3 power, or 0.67. What's been shown more eloquently now by West and colleagues is that our computation of surface and really physiology, these relationships are really driven by fractal geometry, and the area is better represented by the volume of tissue or other spaces to the 3/4 power, or basically 0.75. And so the work by Rubner and by Kleber basically exist within these two expected paradigms in science. Now this is again relevant because our approaches to computation of body surface area that are used for drug dosing also rely on Euclidean geometry. And so what I have here are basically graphics from about 100 years ago that used simple computation of body surface area by one example here, which is this is an image from the work of Dubois and Dubois. So Dubois and colleagues essentially took a small number of individuals and paper mache'd them. And after paper macheing them, they removed the paper mache, placed them on the ground, and took photographs of that paper mache. After taking those photographs, they then computed the surface area and derived an equation. So again, that process would have required computation based on smooth surfaces, and the Dubois and Dubois equation is represented here by this equation, which is basically body weight to an exponent and height to an exponent. And other individuals over time have thought this equation to not be representative because again it was based on 9 individuals and then basically included an additional 23 individuals in their model. So Gehan and George tried to expand on this model by studying a larger sample of individuals, but really came up with similar exponents, and I'm going to explain why that's the case. Haycock and colleagues tried to expand this to include pediatric populations. And then we have Mosteller, who wrote a simple letter to the editor in New England Journal of Medicine that simplified a lot of these equations, and this is the equation again because of its simplicity is included in a lot of textbooks and simply includes the weight times height of individual divided by 3600 and is essentially the square root of that. Now I'm going to show you that all these equations have similar answers because they all rely on Euclidean geometry. So with Euclidean geometry, what you have is weight is a function of volume times density, and height, as you can imagine, is just a single dimension. So if you take the exponent over weight, which is a 3-dimensional term, and add it to height, which is a 1-dimensional term, what you will see with all equations that have been constructed to date is all those values add up to 2. And the reason they add up to 2, again, is it's based on Euclidean geometry that has integer-based dimensions, and that's essentially what you see with body surface area, which is meter squared, or which is a meter squared term. And so these body surface equations, essentially several of them have been developed over time, but really are very similar because they're scaling the information the same way. The Dubois and Dubois equation will lead to computation of slightly lower values, and the reason that occurs is because the weight term has an exponent of 0.45, so it has a smaller term over weight and will lead to computation of a smaller surface area. But again, the scaling is essentially the same. So this has dosing implications because if the dose increases with weight or body surface area but clearance does not increase with that parameter, then what you would expect to see is a higher AUC in larger individuals. So is it really acceptable when we think about this, when we're thinking about a milligram per kilogram dose? So if you think about a drug and the drug's product label is reported as 6 milligram per kilogram, if you use that same milligram per kilogram in a 40 kilogram individual, you're going to calculate a dose of 250 milligrams. If you use that same in a 160 kilogram person, you would calculate a dose of 1,000 milligrams. On average, you would calculate a dose of 500 milligrams. So the question often is that okay? Again, this is a common thing that we do in practice. We address this issue often in obesity by using another weight parameter. And so now let's discuss what those other weight parameters might be. One of those is lean body weight, which we often think of as a good metric of muscle mass. Now, measuring lean body weight is not as simple as we would think. When you think about measurement, even acquiring total body weight in a very large or morbidly obese individual is not simple. It's not simple because a very large individual may not be ambulatory, and so it's difficult to actually get a body weight. You may also not have the right scales in your institution to compute body weight for very large individuals. Computation of height also may be compromised if this is not done correctly. Measurement can also include use of other modalities such as bioelectric impedance analysis. You can have underwater weighing. You can have DEXA, which is an X-ray based method. Or you can have a more recent method which relies on air displacement plethysmography, which again, these systems can be used in healthy individuals, but often not a system that can be used in acutely ill individuals. Because of this, we often rely on estimation, and that estimation happens with several equations such as the ideal body weight, all the way to the predicted normal weight, and I'm going to review some of those equations with you. When you think about these descriptors, total body weight is often sometimes referred to as actual body weight, so there's different terms used in the literature, and this is measured, and as I mentioned, not always easy to do. We have the ideal body weight equation, and this is an equation that was developed over time and referenced for the first time in 1974 by Ben Devine without an actual source. And as a resident, this was one of the first questions I had to tackle through a literature search, was finding the origin of the ideal body weight equation. And what I discovered was it was simply a rule of thumb, a farmer's rule of thumb that was based on our principle of fives, because again, what you see in the literature is this love for the number 5 because we have 5 fingers. We believe that 5 kilograms for every inch over 5 feet would represent an ideal individual. And so this term, again, that's been used in pharmacology was based on a very simple rule that men start at 110 pounds and gain 5 pounds for every inch, and women also gain the same weight for every inch, which again is not a reasonable hypothesis. Because the ideal body weight term did not work for several drugs, a modification was done, and that modification was called the adjusted body weight. This was tested primarily with the aminoglycosides, and a correction factor was found. Now that correction factor in the literature actually ranges between 0.2 and 0.94, but on average is between 0.3 and 0.5. And so what you see in a lot of textbooks is the average of these averages, which is 0.4. And so the adjusted body weight is simply saying 40% of the difference between total and ideal body weight plus ideal body weight is what we would term the adjusted body weight, and then use that weight to compute the dose of the drug. Again, whether or not these are truly accurate ways of representing body weight, what's been shown is that they help dosing of certain drugs. We also have other weight descriptors that have been defined using more scientific methods, such as bioelectrical impedance, and also based on animal data. And the best representation of that is the most recent equation known as the lean body weight 2005, or the Janmashatian equation. This was based on 300 individuals in Australia, where they relied on body mass, body electrical impedance analysis to compute lean body weight. And this equation has been used in the literature in more recent times and computes lean body weight as a function of total body weight and body mass index with slightly different parameters based on males and females. But again, all of these equations are essentially transforming height and weight into different metrics. And so that's an important thing to remember, that all we're essentially doing is taking height and weight and transforming them mathematically into another term. So I want to highlight again what's been done in the literature, just to show that there is some harmonization in the principles that I've laid out in this lecture. One of the approaches that's often used in pharmacy is using a combination of total body weight, ideal body weight, and adjusted body weight. Now you can imagine if you're using total body weight to dose a drug, as a person increases in body weight, you would get a proportionate increase in the dose of the drug. And clearly that's not necessarily a good idea, especially in the extremes of weight. If you were to use that weight distribution, actually if you were to use the height distribution, because again ideal body weight is based simply on height, you would get a distribution of weights computed in this manner. If you then used adjusted body weight, you would get another distribution of weight. And then if you used a combination based on this metric of that's often used in the literature, you would get this distribution of dosing weights across a population. And then if you model that data, what you essentially show is using those distribution of weights essentially gives you a dosing weight function that's 3 times total body weight to the 0.72 power. So in essence, what you see in the literature are really divergent methods of actually dosing drugs, but in reality, in mathematical reality, these are really congruent approaches of scaling doses. And really the objective, again, whether you use body surface area or use an alternate body size descriptor, is you're essentially preventing someone from getting twice the dose as would a normal weight individual. So again, this brings the question of who is right. Should we be scaling to this power or that power? And the reality is that there really the answer exists somewhere in between that. When you look at this study by McLean colleagues, what they've demonstrated is it's really drug dependent. And so on average what you find is several drugs will scale based on body surface area, but some drugs where the exponent is closer to 0 would imply that a fixed dosing strategy would be better, and other drugs using actual body weight or total body weight may actually be beneficial for the dosing of the drug. But on average you would expect most drugs to be dosed on a parameter such as body surface area. This is relevant because when we think about drug development, current paradigms include more physiologic based pharmacokinetic modeling systems, and often what's seen in the literature is reporting of values based on a kilogram basis, and that kilogram basis is often used to scale information. And so it's important to ensure that the methods that are being used to scale information in obese individuals are scaling them using some sort of factor and not in a linear way. So essentially what needs to be done is ensuring that when this physiologic based models are used to derive estimates in obese individuals, that they're being scaled appropriately based on information that's actually derived from the drug in question. So now that I've gone through a lot of theory, what I'd like to do is actually go over some key examples to illustrate how this impacts drug dosing. When we think about the source of these different weight descriptors, the aminoglycosides serve as the key example. These are drugs that have a volume of distribution between 0.25 and 0.35 liter per kilogram. What we've recognized over the last 70 years with these class of drugs that were first classified as antibiotics are that there's a higher risk for toxicity when you're dosing them on total body weight, and that you can adjust the doses of these drugs based on kidney function. And in this case we actually also have therapeutic drug monitoring available that can allow you to modify the maintenance dose. There are several alternate body size descriptors that have been used. These drugs are relatively small in size. They have low plasma protein binding. We also know that the clearance of this drug correlates very well with the glomerular filtration rate. The dosing of this drug is based on body weight, and when you look at the literature there's a range of doses between 1 and 7 milligram per kilogram based on the indication of the drug. And again, in most institutions the dosing is individualized based on therapeutic drug monitoring. This is a study that I conducted over a decade ago, looking at almost 2,000 individuals who were dosed on gentamicin and tobramycin across a very wide body weight distribution of 30 to almost 206 kilograms. What we showed in this data set is that if you were to rely on total body weight to scale the volume of distribution of the drug, what happens is you get an unsteady estimate of the volume of distribution. That is, the volume of distribution parameter goes down as the body weight goes up. If you were to use ideal body weight, you see the opposite phenomenon. And again, this is because ideal body weight is a function of height and not weight. Instead, if you were to use the equation that I mentioned, the lean body weight 2005 equation, what you get is similar estimates of lean body weight of volume of distribution across the body distribution. So the implications of that is if you were to define a dose based on lean body weight, you're more likely to have a predictable Cmax concentration for this drug that is considered to be a concentration dependent or Cmax or AUC driven drug, and I'll show you how this actually also can affect the AUC of the drug. This finding also matches what was seen in animal models. So work done by Salazar and colleagues showed a value that was also similar in rats when they scaled the information to fat-free mass or lean mass. Now, with aminoglycosides, when you think about the pharmacodynamics, they're driven both by the peak to MIC and also by the AUC to MIC. And so the area under the curve is also important, and so that's driven by the clearance of the drug. And so what we did is we also evaluated all the different equations that could exist to compute the clearance of the drug and see what the correlations are. And when you look at that, what we found is that the chronic kidney disease and epidemiology equation actually gave us the best correlation. But it's really important to show that even for a drug class like the aminoglycosides that are considered to be well correlated to clearance, that an equation like the CKD equation only explains 50% of the inter-individual variability in the clearance of the aminoglycosides. And so this is again the rationale for using therapeutic drug monitoring to modify the dose of this drug. So when you think about initial dose selection of aminoglycosides, we're perhaps gearing it to a Cmax to MIC target or an AUC to MIC target. But if you're thinking about it from an AUC to MIC target, we would consider the milligram per kilogram dose of this drug. And we may consider different approaches. So when you're thinking about this drug use of tobramycin in cystic fibrosis patients, what's published in the literature is use of a higher milligram per kilogram dose, or 10 milligram per kilogram. And the reason this makes sense is cystic fibrosis individuals tend to be leaner, and because they're lower in body weight, the expectation is the need for a higher milligram per kilogram dose. In contrast, if you're going to think about dosing this drug across a weight distribution, what could be considered is if you're using if you have individuals across a higher weight distribution, what may be necessary is using a lower milligram per kilogram term. And so this again fits within the paradigm because the paradigm is based on 5 to 7 milligram per kilogram, but you may make the decision to use a lower milligram per kilogram in a larger individual. And then the third alternative is saying this may be a confusing algorithm. So instead, if you could use a fixed milligram per kilogram across a population and then use lean body weight, you would then compute, again, very similar doses, but have a simpler metric to dose across a weight distribution. Another approach could be consideration of kidney function as the dosing strategy, and this is if you believe the AUC to MIC to be the driver of the relationship. In this scenario, we've published equations that demonstrate how this could be done, and essentially you would use the creatinine clearance estimate using a Cockroft-Galt equation to compute an aminoglycoside clearance, to compute an initial dose based on this target value. This article for reference also relays how the information can then, if therapeutic drug monitoring is applied, equations are provided that can be used to compute the AUC of the drug to modify the dosing of the drug. Another drug where this is seen to be quite relevant is with the dosing of vancomycin. This dosing historically has been thought to be reasonable based on actual or total body weight, because the volume of distribution of this drug is thought to be very similar to total body water estimates in most individuals. Now there could be multiple approaches that are used. So one approach that's used in current guidelines is to dose the drug based on total body weight. And so when you look at that, using total body weight, if you were to use 25 milligram per kilogram, you will clearly compute a much higher dose in a larger individual. And so for most clinicians, this may lead to consideration of too high of a dose. The alternate in other guidelines, when you're looking at the methicillin resistant Staph aureus guidelines, the recommendation is to use no more than 2,000 milligrams as the dose. And so in this scenario, in a larger individual, you may end up using a 13 milligram per kilogram dose. And so for some clinicians, that may be too low of a dose. So what would be the alternative? One of the alternatives would be to use the same milligram per kilogram dosage, but then use a different body weight descriptor. And so as the individual gets larger, instead of using total body weight, use the adjusted body weight function, and you would compute much lower doses. A simpler alternative could be to scale the doses. And so since most individuals have calculators that have square root function, what I'm showing here is if you take the weight of the individual divided by the average weight and take the square root of it, you would basically be able to replicate the dosing of this drug across a population that would match up to adjusted body weight dosing. When you're thinking about vancomycin, again, this is a drug that also undergoes therapeutic drug monitoring. What has happened over time is guidelines that have suggested that only trough concentrations are necessary. But a point that needs to be highlighted is that trough concentrations do correlate with the AUC of this drug, but only predict about 40% of the inter-individual variability. And so the trough concentration is a simple metric. It's easy because a single concentration can be measured, but it may not represent the true AUC in a specific individual. What we've shown in a series of studies is the importance of getting a peak concentration measurement in obese individuals. And this is really important because Bayesian approaches that can be used to compute the AUC of a drug like vancomycin in a population really needs an accurate estimate of the volume of distribution. And so you can imagine if you are missing a peak concentration measurement, you don't actually know which concentration time profile truly represents the individual. And so you can have different scenarios represented here with the true scenario represented by the actual concentration measurement in a two-compartment model. And so again, when we think about achieving the right dose in an obese individual, a common issue is not being able to approximate what the true volume of distribution is for the specific drug. And so in this scenario, what we demonstrate is the importance of a peak concentration measurement. More recently, we've published a study looking at the pharmacokinetics of vancomycin and looking at alternate metrics. As I mentioned, with the several equations, what we've relied on for over 100 years is using height and weight to compute alternate body size descriptors. Stuart Wong and colleagues at the University of Michigan have led a group known as the Morphomics group. And these individuals have developed mathematical algorithms that can take existing computer tomography data and convert them to different body size metrics. So this graphical representation is taking existing data from individuals who are in the hospital who may have had a CT scan done for some medical reason, and then taking that data to compute parameters such as body depth, fascial area, total psoas area, and several other parameters represented in this slide. What we then did is look retrospectively at the pharmacokinetic profile of vancomycin and assess the correlation of these pharmacokinetic parameters to these newer body composition metrics. What we were able to clearly demonstrate is that the volume of distribution of vancomycin was poorly predicted by body weight and was really better predicted by T12 to T4 which is representing again the vertebral columns T12 to T4 torso area, was a better correlate. But again, looking at this, you'd see a very poor correlation, but in relative terms, a better correlation to body weight. We're also able to demonstrate that using total psoas area, which would be a metric representative of muscle mass, that this metric was a better predictor of clearance than relying simply on body weight. And so again, this more recent study is clearly not ready for prime time use, but just represents a movement away from our simple measures of height and weight to define drug dosing. For other drugs that are just dosed on a fixed dosing basis, drugs like ceftaroline whose pharmacodynamics are based on time above MIC, what you'll see for several drugs and shown earlier is reductions in the peak concentration, but really a convergence in the profile. And so this study by Justa and colleagues out of Keith Rodwell's group at the University of Illinois at Chicago have clearly shown that for certain drugs like beta-lactams, you may need higher doses with the first dose, but really because of this convergence in the profile, maintenance doses probably do not need to be adjusted for most beta-lactams. For another drug like levofloxacin, a drug that's concentration dependent, what's shown in the label is use of a higher milligram dose that allowed really shortening of the dosage regimen from 10 days to a shorter regimen in patients with pneumonia. For this drug, the AUC to MIC is predictive of the response, and the observed AUC of this drug is between 50 and 150 milligram per hour liter. This drug also has a really good correlation to kidney function, and because the clearance of this drug has a good correlation, in theory the dosing of this drug could be improved by computing the clearance of the drug relative to creatinine clearance. Now in the United States, we do not offer therapeutic drug monitoring for drugs like levofloxacin, but this study conducted in collaboration with Dr. Federico Pia at the University of Udine in Italy, what we're able to show is therapeutic drug monitoring can be used to improve the dosing of drugs in individuals across a much larger body weight distribution of 98 to 250 kilograms. What we're able to show is those individuals may need doses higher than 750 milligrams to achieve isometric exposures to those that are smaller in size. But again, the critical piece here is that therapeutic drug monitoring was available to ensure that we didn't overdose individuals. And so this recommendation of using higher doses is truly off-label and cannot be recommended in clinical practice in the United States. But for institutions that do have therapeutic drug monitoring, it does create a mechanism to consider uses of higher doses of drugs to achieve the exposures necessary to improve outcome of a drug like levofloxacin. Additional examples for other drugs that are not antimicrobials include work by Dr. Catherine Neeb's group at the University of Leiden. This group has done several studies looking at specific probes of CYP metabolism, and they've done a really nice study more recently with midazolam looking at a population of individuals who've undergone bariatric surgery. And so this is an important study because this study allows an evaluation of individuals as their own controls. So this would represent, this figure here represents individuals who are larger, who are obese, who undergo bariatric surgery, and over a 1-year span lose quite a bit of weight. And because they lose weight, and you can measure pharmacokinetics before and after weight loss, you can look at changes in drug clearance. And what they've shown with midazolam, which is a probe of CYP3A4, is that the systemic clearance increased with this drug with weight loss. But there's really no alterations in oral bioavailability. And so this expectation is different again because we would think in terms of do we need to increase the dose for body size? In this scenario, the idea is we perhaps may need to lower certain doses of certain drugs if this is really true in obese individuals. For other drugs like acetaminophen, this is actually metabolized by multiple pathways, and so it's not really a good probe for CYP2E1, but this is an important study because this study shows a shift in the metabolic profile in morbidly obese individuals represented by the blue box plot versus the green box plot of non-obese individuals. What you see is an increase in the cysteine, and although not statistically significant, increase in the mercaptopurate metabolite of acetaminophen, metabolites that would be associated with the hepatotoxicity potential of this drug. And so in this scenario, even though clearance may increase with the drug like acetaminophen, recommendations cannot be made to increase the dosage of a drug like acetaminophen because this may lead to increase in toxic metabolites of the drug. And so studies like this are really important to, because they can give us good insights on whether doses should be changed in certain populations, but really if metabolites are also changing in those in obese individuals. Another important compound that's been evaluated is Propofol, and so this study again by Neeb and colleagues looked at the glucuronidation profile of Propofol and really were able to show that the clearance of a compound like Propofol, which is a very low molecular weight small compound, best scales allometrically. And this is going to be again a phenomenon that's seen with several drugs again, is that for most of these drugs we would expect that the clearance of the drug to scale to an exponent of 0.67 or 0.72. And that is essentially what was seen in this study, implying that perhaps body surface area or a metric like that may be reasonable to the dosing of Propofol. Now this has been actually investigated in much more detail by Eleveld and colleagues who have taken data sets across different weight distributions and across different populations of adults, children and elderly, and have come up with a much more complex and comprehensive model that not just deals with the issue of obesity, but really deals with the overall profile. And this is a process that's being heralded through the OpenTCI initiative and is an important one to help improve the dosing of compounds like Propofol that are used in anesthesia. So what I've presented today is a lot of different paradigms that are currently used to define the dosing of drugs in obesity, but it's important to consider that if we have some drugs where we shouldn't be dosing them on body weight, rather where we should be dosing them on a fixed basis, how do we change that dosing paradigm? And if we're going to do that, how do we pay attention to improving the dosing of a drug once a drug is marketed? So I'd like to present in the last few slides here is the data with daptomycin. So this is a study that I performed about a decade ago at the University of New Mexico, where we looked at morbidly obese versus normal weight individuals and dosed daptomycin based on body weight. And what we saw is very small change in the volume of distribution of this drug, even though that the weight of individual was almost twice as high in the morbidly obese versus the normal weight individuals. The volume of distribution did not increase proportionately to body weight. We also used bioelectrical impedance analysis to compute the fat-free mass of these individuals. And when we did that, we actually were able to normalize the volume of distribution, implying that total body weight is not the right metric for this drug. When we looked at clearance of this drug, we were also able to show that the clearance of this drug does not increase proportionately to body weight. And again, this parameter was scaled better with fat-free weight. And in this scenario, we also looked at measurement of clearance because these individuals were matched on their sodium iothalamate glomerular filtration rate. So this is a well-performed study, and we were able to show again that neither of these parameters really scaled to body weight. And this is important because this drug is currently dosed on body weight on a 4 milligram per kilogram and 6 milligram per kilogram basis with specific guidance to not modify the dose for obesity. There are also recent guidance that suggests that the dose of this drug should be increased to 8 to 10 milligram per kilogram, which would imply much higher exposures in obese individuals. More recently, we published a study in collaboration with Marco Falcone and colleagues at the University of Rome. And this study was based in individuals that were critically ill. And in these 50 individuals, what we were able to show again is that body weight does not correlate with the clearance of this drug. Rather, there were certain individuals who had augmented clearance of this drug. And in fact, what we were able to show is individuals who had bacteremias, who were sicker individuals, tended to have higher clearance. And that clearance was not related to body weight. Again, we were able to discover that through therapeutic drug monitoring, which is widely not available for this drug. Now, our findings are consistent with the original findings from over a decade ago. So if you were to look at the original population PK model for a drug like daptomycin, what you would see is the clearance of this drug was actually related to body temperature, which is, in most cases, when you're looking at this, you'd say that this is an odd term to incorporate into a population model. But what it really represents is this idea of illness. If someone has a severe infection, they're more likely to be febrile, and if they're likely to be febrile, their temperature will be higher, and so you would compute a higher clearance. They also incorporated renal clearance in the term, but when you looked at the function, most of that clearance is not really driven by kidney function. There's just a value of 0.807, which was the same value that we saw in our healthy volunteers. Now, if you look at this again tabulated and using a referent population, what you would expect is even if kidney function increased and body temperature increased, your maximal expectation for clearance across that population would be no more than a 70% higher clearance, which would imply that the dosing of the drug or the absolute dose of the drug does not need to be increased by more than twofold. So again, if you're going to dose a 50 kilogram person versus a 150 kilogram person, you would dose that individual, the 150 kilogram person, 3 times more if you used total body weight. And clearly the mathematical expectations are that that would be too high. This has also been shown in febrile neutropenic patients when you're thinking about the effects of severity of illness and clearance. Now this is problematic because how do we solve this issue once a drug is on the market? So the product label currently recommends that the drug be dosed on total body weight. And so some investigators have suggested in larger individuals to switch scalars. So instead of using total body weight, because you would accidentally perhaps calculate too high of a dose, consider switching to lean body weight. And why this is an issue is if you were to look at the distribution of lean body weight across a population, this is a representation of the lean body weight in males, and this is a representation in females. If you were to use these distributions, you would get this phenomenon. You would dose individuals between 50 and 111 kilograms on total body weight, and so what would happen is you would compute a dose between 300 and 666 milligrams, and then by switching scalars, what you'd essentially do is drop the dose for individuals that are larger. So the effect of switching scalars for some drugs is you would end up giving larger individuals much smaller doses than they need. And so our group has proposed consideration of fixed dosing strategy for this drug to essentially give similar doses across a population, but that recommendation also needs to be validated through a prospective study. So to summarize the key points that I've laid out today, obesity is associated with changes in volume of distribution that may require the use of higher initial doses relative to maintenance doses. Our expectation is obesity has limited changes in drug clearance, and that for the majority of drugs, those changes are likely explained by allometry. We also expect that total body weight may be reasonable for an initial dose, but it's really unlikely to be a useful metric for defining the maintenance dose. And the loading dose of a drug could be used to aid the dosing of drugs that are time dependent, pharmacokinetics, but we should really move towards consideration of body size stratified or composition stratified dosing regimens for computation of the maintenance dose of a drug. With that, I'd like to thank you for your attention. I'd also like to thank Dr. William Figg and Dr. Lisa Cordes, the National Institutes of Health, for this opportunity to present in the Principles of Clinical Pharmacology. If you have any questions, please direct them to the coordinators of this course.